Wonderful. So it's great to see so many of you here. And I just want to briefly introduce the speakers today. So my name is Rohini Bajekal, for those of you who didn't meet me yesterday, and I'm the communications lead at Plant-Based Health Professionals UK and a nutritionist. And I'll be talking about PCOS and endometriosis, and specifically the role of plant-based nutrition and lifestyle. And then we're going to be hearing from Lisa Simon, who's a fantastic registered dietitian, who's going to be talking all about optimizing fertility with a plant-based diet, and then hearing from my mother and senior consultant OBGYN, Dr. Nitu Bajekal, all about perimenopause and menopause. So definitely use Slido, ask your questions, and let's have a really engaging Q&A at the end as well. Just a little housekeeping rule, please make sure your phones are on silent and try to keep discussions to a minimum during the sessions as well so everyone can hear. Fantastic. So, I already mentioned what I do. I'm also board certified in lifestyle medicine, and just full disclosures, I've also co-authored a book with my mother on PCOS called Living PCOS Free, which is downstairs in the exhibitor section. And I regularly give talks on PCOS to GPs and other places. I run my own clinical practice, and I've personally been following a plant-based diet for almost 15 years and personally identify as vegan as well. So the learning objectives today is to understand the role that nutrition plays in two extremely common but very distinct conditions that affect women and people assigned female at birth. The first of which is PCOS. We can really think of this as the PCOS pandemic. At least 1 in 10 women do have features of PCOS, which stands for polycystic ovary syndrome, or polycystic ovarian syndrome, as it's sometimes referred to. And it's the most common endocrine disorder worldwide, the most common hormonal disorder worldwide, but it's absolutely alarming that so many people haven't heard of it. And about 75% of people living with the condition are not yet diagnosed, which is appalling. And we know that actually in some subgroups, such as those living with excess body weight, those dealing with infertility or subfertility, and people from certain ethnic groups. So in India, the prevalence is thought to be as high as 1 in 4, which is staggering, and it's a really growing issue around the world. It's a complex genetic trait, and like endometriosis, is thought to develop due to changes in the intrauterine environment when you're in the stomach of the person who carried you. So it's a really complex condition that starts very early, and if you've got family members who've got type 2 diabetes or who've got PCOS, they may also remember, some people don't even know they have PCOS, but if you've got that in your family, then there is a higher likelihood that you will carry that yourself. And it's a complex interplay between the genetics and also lifestyle in terms of how it's expressed, the symptoms you have, and so on. And there was a UK Biobank study in 2020, which fascinatingly showed that this study of 175,000 men that actually showed men can develop characteristics of PCOS too. And it's not just this gynecological condition that we think of, it's an endocrine condition, with men developing symptoms such as male pattern baldness, type 2 diabetes, metabolic syndrome. So there is that aspect as well. It's not just something that affects the ovaries. And there was an economic meta-analysis in 2020 in the USA, which showed that PCOS and its associated complications and costs, it costs up to 8 billion. And we're going to come to endometriosis later, but the cost of that is 22 billion in the USA. So together, these conditions are costing the US economy over 30 billion. And as individuals, they can be very expensive conditions to manage, with lots of different symptoms to control, treatments, and long waiting times as well on the NHS. So diagnosing PCOS, so many people are sometimes confused, do I have PCOS? And there's actually a criteria that was developed in 2003 by experts in Rotterdam who sat down and identified these 3 criteria. And it's a diagnosis of exclusion. So just because someone has irregular or missing periods, you can't automatically assume they've got PCOS. There can be things like Cushing's, rare tumors, things like hypothalamic amenorrhea, which is when the periods stop or become irregular due to underfueling and sometimes overtraining as well, low body weights. So if someone is very lean, that needs to be ruled out as well. And I have seen plant-based eaters having both PCOS and hypothalamic amenorrhea. So it's a diagnosis of exclusion. And you need to have the first two out of the three if you're going to be diagnosed with PCOS as an adolescent. So, people don't tend to rush in and label teenagers as having PCOS without, making sure that that criteria is met. But for any adults, so over the age of about 8 years after you start your first cycle, you need to have 2 out of 3 of this criteria. They're irregular or missing periods. And irregular or missing periods would be any cycles that are long, so over 35 days, or they oscillate dramatically. Usually with PCOS, you'll see cycles that are kind of once every 72 days, once every 30 days, at 35 days, then it will be 90 days, and it will just sort of go. Some people don't have periods at all. As well with PCOS, but cycles are irregular. They don't come within that predictable interval of between 24 to 35 days. A normal cycle would be 28, 30, 29, 32, 30 days. That's a sort of normal cycle, but yeah, within that 24 to 35 day window. Hyperandrogenism as well, so symptoms such as excess hair growth, acne, losing hair from the top of your head, and an ultrasound scan with polycystic ovarian morphology, which is quite common in young women anyway, but with PCOS you do tend to see kind of 12 or more follicles. Now the criteria has actually changed to sort of 20 or more follicles per ovary, but just because you've got polycystic ovaries doesn't mean you have PCOS as well, so that's why you need this criteria. The symptoms are really wide-ranging, and every single person with PCOS is really unique, so I treat everyone as an individual and understand that not everyone is going to have all of these symptoms. They may have very few, some might have a lot, but there are commonly recognized ones, things like the acne, gaining weight easily, losing hair from the top of your head, having excess facial and body hair. But there are things that hardly get recognized, things like eating disorders. 21% of people with PCOS are living with an eating disorder, and binge eating disorder is the most common of that, and that often doesn't get recognized because that is affecting a lot of people living in larger bodies. Insulin resistance, which we're going to talk about, 15-fold increase in fertility issues. About 80% of people with PCOS will struggle to fall pregnant, but most of them do go on to get pregnant and have a child if that's what they want. Psychological issues, increased risk of anxiety, depression, obsessive-compulsive disorder. If you've got PCOS, you're 7 times more likely to take your own life. So this is a really serious whole-body condition that doesn't just affect your ovaries or your fertility. And sexual and relationship dysfunction, lower body image scores, sleep disturbances, and excess weight. 80% have got excess body weight. So what are the drivers? So insulin resistance is thought to be the key driver of PCOS, and you do see that that being responsible for a lot of the symptoms like the acne and the excess hair growth. That insulin levels are high along with IGF-1, and that stimulates the ovaries to produce excess testosterone, such as testosterone, which is the most commonly known one. Testosterone is not just a male hormone, it's found in all genders, and you actually can't have estrogen without testosterone. So we should take away that language in PCOS is saying male hormone, male pattern, things, it's quite harmful to people with PCOS. 60 to 80% are living with clinical obesity or overweight, and a third of people with lean PCOS, third of lean PCOS also have intra-abdominal fat on MRI scans. About 20% of people with PCOS are not living with excess weight, so you can be lean and have PCOS. It's really important to know that as well. So lifestyle. A lot of people don't realize that lifestyle is actually the first line of treatment in PCOS. Why aren't we telling people this? So that means lifestyle interventions, including nutrition, movement, stress management, can play a huge role. PCOS is not just about fertility, as we see in the media, but there's an increased risk of so many chronic diseases and conditions like metabolic syndrome. Over half of everyone with PCOS develops type 2 diabetes by the time they're 40. That's the official statistic from the CDC. increased risk of womb cancer, sleep apnea, where your breathing stops and starts when you're asleep, fatty liver, higher risk of cardiovascular disease factors, so raised LDL, and that's why the lifestyle can play such a big role. When it comes to plant-based nutrition, it is so powerful for PCOS. And whilst I will say there isn't this one diet for PCOS that's been identified by experts and in the national and international guidelines, they do recommend a diet that is rich in whole grains, fruits, vegetables, beans, nuts and seeds. And that sounds exactly to me like a largely whole food plant-based diet. So yes, we need to bring that fiber in. It's really, really key. And weight loss can be achieved on any diet, but I always encourage people, don't just look at that number on the scale. Look at the health, look at it holistically, look at the mental and physical well-being of the person and their long-term health and the sustainability of that way of eating. Ketogenic diets, whilst they may be effective for some people with weight loss, are they sustainable? Can you sustain that? Can you have a healthy heart, a healthy brain? All of these things need to be taken into consideration as well. And with only 1 in 10 UK adults meeting the fibre recommendation of 30 grams a day, we need to be getting a lot more plants into our diet. So with a plant-based diet, it specifically tackles that insulin resistance and helps the cells become more sensitive to insulin, be able to take in that glucose. So it really can help with a lot of the symptoms of the acne and the hair growth and things. It helps with sustained weight loss and maintenance. And we know that losing 5 to 10% of your body weight in PCOS is enough in many to help restore ovulation. So get your cycle back to help you fall pregnant if that's what you want. But also a healthy cycle is important for many more things beyond just falling pregnant, for normal hormone production, for bone health, as we're going to hear in the session after the break, and lowers inflammatory markers like C-reactive protein and homocysteine and oxidative stress and immunity. The root cause of PCOS and endometriosis is that inflammation. So we need to quiet that through the diet and what the foods are that we're putting into our body. It helps also to reduce the circulating androgens like testosterone and SHBG, which tends to be higher on plant-based diets, which is a positive thing, and improves the lipid profile as well, so reducing your cardiovascular risk. Remember, cardiovascular disease is still the top killer of women globally, so it's something we all need to think about, and improves that gut dysbiosis. If you've got PCOS, you've been found to have less beneficial bacteria in your gut as well, so you do want to be thinking about gut health, and the only foods that have fiber are plants, so that's where plants come in. And it's naturally lower in advanced glycation end products, which I talked about in my talk yesterday, but advanced glycation end products, or AGEs, are when fat and protein combine with sugar in the bloodstream, and whilst our body naturally produces them from the very early time, these compounds, these heterogeneous compounds, are thought to be quite inflammatory. They increase the risk of certain cancers, type 2 diabetes, heart disease, and we can also get them from external sources. So smoking is a huge source of glycotoxins, and it's really harmful to the ovaries. So we advise everyone who's got PCOS, or anyone really, not to smoke, but also processed meat, high temperature cooking, ultra-processed foods like sort of crackers and crisps and things like that are no good if you've got PCOS. We also want to eat in line with our circadian rhythms. I'll talk a little bit more about what to eat, but plant-based diet aside, what time are we eating? There is circadian rhythm dysfunction. That means our body's internal clock is out of sync when we've got PCOS. The same way that you see that with night shift workers, you also see that in perimenopause and menopause. So something we can all benefit from is optimizing our circadian rhythm function. A short morning walk is something I tell all my PCOS clients to get in. 15 minutes, get out first thing, and eating larger meals earlier on in the day can really help to optimize insulin sensitivity. There was a fantastic study done by Hanna Karliova looking at type 2 diabetics there. But remember, so you want a breakfast like a king, lunch like a prince, dinner like a pauper, and have a light dinner by 7 p.m. to optimize that restorative sleep. Another really, really important pillar in lifestyle that doesn't get talked about enough, but gets disrupted in PCOS. So now we come to endometriosis, which again affects at least 1 in 10 and is highly, the familial aspect is quite strong in endometriosis, and it can be a debilitating condition with people really struggling with pain and other symptoms. But it's when the lining of the womb grows outside of the uterus, so you get this sort of endometrial tissue in other parts. It can be in the bowel, it can be in the pelvis, they've even found endometriosis in the nose and the lungs and things, although that's rarer. And it can cause symptoms like painful intercourse, pain when going to the bathroom, constipation, fatigue. It's a leading cause of infertility as well, and one of the hallmarks is those kind of heavy or painful periods. It can be silent in some people as well. And there's a higher risk of other comorbidities because, like PCOS, it's thought to have that autoimmune component. So increased risk of cardiovascular issues, autoimmune, arthritis, fibromyalgia. And it can take about 8 years to diagnose. Environmental factors is something I address in my book for PCOS, and it's the same for endometriosis. We want to avoid things like plastic water bottles and lots of, fragrances and things like that with both conditions. And my mum's got a fantastic fact sheet on endometriosis treatment, so I won't go into the medical stuff in too much detail. With the dietary risk factors, there are limited studies because, let's face it, women's health is sorely underfunded, under-researched, doesn't get talked about enough. But alcohol is extremely inflammatory, a class 1 carcinogen. 3 drinks a week raises your risk of breast cancer by 15%. And with endometriosis, we know it both increases the risk, but it also increases that inflammation and oxidative stress and raises estrogen levels. And endometriosis is a pro-estrogenic condition. It's something that we want to try and reduce. So red, white, and processed meat should all be off the table with endometriosis as much as possible. In the Nurses' Health Study, 81,000 women were tracked, and those having over two or more servings per week of red meat had a 56% higher risk of endo compared with those consuming 1 or less servings per week. And processed red meat, which we heard about this morning as being extremely detrimental, also had a 20% higher risk of endo. And even chicken increases risk through that heme iron, the organic pollutants, and all the other stuff, nasties that are found there. So what do we want to include in the diet? We want to include things that really help foster a healthy gut microbiome, anti-inflammatory, plant-based foods, and fruits, particularly citrus fruits, have a really protective effect. So getting those citrus fruits in, 22% reduce risk of endometriosis, and dark leafy green vegetables as well. But do consider FODMAP sensitivity. Often women with endometriosis present with IBS-like symptoms, and they find that cruciferous vegetables like cauliflower and broccoli can increase their pain. So if that is the case, because those foods are so nutritious, I don't like to completely cut them out, but sometimes, slowly reintroducing them, cooking them for longer, trying different ones and considering that. And we have a fact sheet on the low FODMAP diet and plant-based diets on our website, but you do need to see a registered dietitian. You shouldn't be trying low FODMAP yourself. It's not a sustainable diet. But if you've got a lot of pain when you eat those healthy foods, then you need to look at that. And then there's smaller studies on things like soya, green tea, turmeric, and seaweed, but we still need more studies on endometriosis. Supplements, I advocate as a nutritionist a food-first approach. Let's focus on the food on our table, but there are supplements that can play an important role. Vitamin D, people with PCOS have been shown to have lower levels of vitamin D, so they may need slightly higher amounts. Inositol is a big buzzword in PCOS right now, and it's found naturally in things like whole grains, fruits, beans, that you can opt for a supplement that can be particularly helpful if you're trying to conceive potentially. And omega-3 fats in both conditions. In endometriosis, it can reduce pain and pro-inflammatory prostaglandin formation and also help decrease that inflammation. And remember, everyone on a plant-based diet should be taking B12 anyway, but if you are on metformin with PCOS, that can reduce absorption, so you might need higher levels. And everyone on the contraceptive pill should take a multivitamin, multi-mineral supplement as well. So to conclude, all 6 pillars are key in managing hormonal health. It's not just about nutrition, but that is a cornerstone. So prioritize those intact whole grains, which won't raise your blood sugar as quickly. We heard how fantastic they are this morning. Get that diversity of plants in. exercise. It's not just that aerobic exercise. A lot of people with PCOS and endo find that lower to moderate intensity exercise really suits them. Things like yoga, walking, Pilates, sleep management, stress management, because these are very stressful conditions to manage. So you have to really find what works for you, whether it's acupuncture, breath work like we did this morning, meditation, psychotherapy, avoiding risky substances like tobacco and alcohol, which really have no place in managing PCOS or endo, fostering positive connections. And there are amazing support groups like Verity and other things. If someone wants to come and chat to me, I'm very happy to give you some more tips. And then plant-based community, family, friends, anyone you can just share your experiences with. Please encourage your clients, your patients to do that and to get that support. Focus on colour. This is a message for everyone, but get that colour in. If you don't want to focus on all the different nutrients, just get all that amazing colour into your diet. And we're going to get more talks and hear more information about that. But this is kind of more similar to how I eat most days. So this is a little bit about my story. I've actually never shared, but I got diagnosed with severe endometriosis a few days before Christmas last year, and it came as a real shock because I'm in my mid-30s, and a lot of people assume if you've got one, you can't have the other, but actually 5 to 10% of people do seem to have both PCOS and endometriosis. My PCOS journey sort of started when I was at university. I grew up vegan actually from the age of 13, and when I was at university, my diet radically changed from the healthy home-cooked food I'd grown up with, and I started to eat a really ultra-processed vegan diet, lots of binge drinking because I was very insecure, had very high anxiety levels, and I was very conscious of my acne. And stopped moving as much, didn't exercise, was studying all the time, and really struggled with all of the PCOS symptoms that we've mentioned. And lost a lot of hair from the top of my head, was gaining weight easily, had a lot of acne, as you can see, and I struggled for years until I moved to India in my mid-20s, and I started to make lifestyle changes. The alcohol, the movement, all of it. It was a whole approach, and getting more whole plant foods and retraining to become a nutritionist and help other women living with PCOS so they didn't have to struggle. And it's really key that people understand pain is not a feature of PCOS. You can have some heavier periods with PCOS. Sometimes some women have a bit of pain, but if you've got pain which is what I had, where you're in bed for several days a month, that is not normal. So please advocate for yourself, listen to yourself. I should listen to my mum, but just advocate for yourself because you can have both conditions. But I am definitely feeling way better than I did in my early 20s on a whole food plant-based diet, managing it through lifestyle. And just ending with this quote, if you listen to your body when it whispers, you won't have to hear it scream. And I think we can all tune into our body more and the signals it's giving us. So lastly, just to say, my book is not just for people with PCOS. My mother and I wrote it for anyone who wants to reduce their risk of chronic disease and improve their hormonal health. There's real-life case studies. There are over 30 plant-based recipes from our kitchen, lots of over 500 scientific references, so it is all evidence-based. And if anyone wants to come and chat to me later or reach out to me on Instagram, I'm very happy to answer questions. But I'm going to hand over to Lisa now to kick off. Thank you.
Put my timer on. Good morning, everyone. So I'm going to talk to you today about optimising fertility with a plant-based diet. I'm Lisa Simon, I'm a registered dietitian. So just to disclose, I am a published author of the Plant-Based Dietitian's Guide to Fertility that was published this year, and it's the reason why I'm speaking to you today. So this is the content of my presentation. It's a bit of a whistle-stop tour, I'm afraid. I'm going to have to speak quite quickly to make sure I cover it all. But starting off with my personal story. So I know, he's so cute, isn't he? I experienced amenorrhea for well over a decade. So for me, that was a complete absence of periods. And if I added up, it was actually around 17 years this happened. So when my husband and I tried to conceive, we struggled. And after 2 years, we went down the IVF route. And mainly because of our ages. So I was 37 at the time and he was 42. And it was during this time I stumbled across plant-based nutrition because I was looking for anything that might help improve our outcomes. So to cut a very long story short, I eliminated all animal products apart from dairy at the time because I didn't know much about plant-based nutrition. I was worried about eliminating sources of calcium, and especially because thankfully the first round was successful, and I was worried about giving up that during pregnancy as well. Now I know different, of course, and I'll explain a bit more about that later. So here is my son, who was, he's now 5, so this is a bit of an old picture, but wearing his favourite food, which still remains bananas. And this is why I'm so passionate about this subject, because there really is so much evidence on optimising your fertility with a plant-based diet. So what is infertility? The World Health Organization's definition is a disease of the male or female reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected intercourse. And I've just highlighted in bold the words I don't like in that definition, so it isn't always a disease. We know for a fact that the majority of people accessing treatment, the reason is because of male factor infertility. And out of those, a large percentage is due to issues with the quality of the sperm and not because of a disease. And also failure. You know, I don't like that word. As a female, especially, I felt a complete failure every single time that I failed to conceive. So to have that word in a clinical definition is not very helpful, and I'm hoping that that is going to be reworded. We know that infertility rates are increasing, with about 8 to 12% of couples affected globally, so quite a significant number of people. And there are more people now accessing fertility treatment. So the first test tube baby was born in 1978. Her name was Louise Brown in Manchester. And the Human Fertility and Embryology Authority report in 91 showed that just 6,700 IVF cycles were performed at that time. Fast forward a decade, and that had increased to 69,000. We don't have data past 2019 at the moment because of COVID, so they're hoping to validate that by the end of this year or early next year. And chances have increased as well. So in 91, there was just a 6% chance of a live birth. And in 2019, that had increased to 25%. And when I had my treatment in 2017, that was about the odds I was given as well. So, I mean, they're still not great, but they're improving. There are differences in women in same-sex relationships accessing treatment as well. So in 2009, there were just 489 IVF cycles, and 10 years later, that would increase to just over 2,400. And also women going through treatment alone. So 565 cycles in 2009, and 1,470 in 2019. Unfortunately, though, there remain big inequalities in fertility care, because the majority of research, policies, planning, service provision, also education leaflets are aimed at heterosexual couples, and even the World Health Organization definition excludes people who really would love to become parents but are biologically unable to without the help of a sperm donor or surrogacy or fertility treatment. And it very much remains a postcode lottery. So there was a national audit published last year that showed that not only are the majority of clinical commissioning groups, or CCGs, not offering the full 3 NICE recommended IVF cycles in many parts of the UK, but relationship status seems to be affecting access to treatment as well. So just 21% were giving to single women and 73% to women in same-sex relationships. And even then, you have to prove your infertility. So unlike heterosexual couples who need to try for 2 years before they can have IVF treatment, women in same-sex relationships have to self-fund up to 6 rounds of IUI, so intrauterine insemination, before they're eligible for IVF. And that can be really crippling because each round can cost up to £1,600. So this glaring inequality was addressed recently in the Women's Health Strategy for England, and it's led to a new pathway created in the NHS, where same-sex relationships will be given 6 rounds of funded IUI before IVF. I don't know when it's going to be rolled out or whether it's UK-wide, but I'm really, really hopeful that it will be. The exploration of ethnic inequalities is also really limited because historically the large majority of studies have been looking at women going through fertility treatment, and as ethnic minority groups in the UK, there's only small numbers in those studies, then the exploration is very, very limited. And this may lead healthcare professionals to have a lack of understanding of their patients' experiences, and that includes language barriers, and stigma in the patient's own communities as well. And also there's differences in why different ethnic groups are accessing treatments and experiencing infertility. So for example, uterine fibroids in white women prevalence is 6.9%, but in black women it's 25.5%. And also ovarian reserves in African American, Chinese and Latino women are much lower than white women. And there could be many reasons for this, including genetics and differences in reproductive hormones, but ultimately more research is needed. Now, the preconception period is a crucial time, and this is any time before you're trying to conceive. And it's a crucial time for optimising egg, sperm and placenta health, and also optimising the baby's long-term health, which is called developmental programming. So we know that the health of the sperm and the egg really do have an impact on the baby's long-term health as well. And we like to see positive changes 3 months or more prior to trying to conceive. If there are known preconception risk factors, such as being significantly under or overweight, then it's recommended that you wait 6 months or more. And positive changes include maintaining a healthy weight, predominantly exclusively following a plant-based diet, which is obviously what I'm speaking to you today, cessation of any risky habits like smoking, alcohol and recreational drugs, really looking at stress management, and I can't actually highlight how important stress management is, and I go through that in detail in my book. Doing moderate, so not really excessive and regular exercise, including strength and cardio, and supplementing correctly but not excessively, and I'll talk about that in a minute. So we know there are multiple benefits of plant foods on fertility, and we always say eat the rainbow. And plants contain phytonutrients, which are the pigments in plants, and they exert antioxidant, inflammatory and microbial actions. Eat in season varieties where possible because these phytonutrients are more concentrated there. The most common, which accounts for over 60%, are polyphenols, and there are over 8,000 of these. So I've just put a list of polyphenols there, down the left-hand side, and just some of the sources, but obviously there are many, many, many more. Now we know that fibre is important for gut health and for general health, but it's also really important for fertility. So it can help prevent spikes in insulin and blood glucose levels, which makes conditions like polycystic ovary syndrome much easier to manage. It helps maintain hormone balance because it can bind with excess hormones in the gut and remove them in your stool. And it can also help keep you satiated, and it does this in 3 ways. So beta-glucan, which is soluble fibre found in foods like oats, slows down the passage of food in your gut, so it increases the absorption time of that food. You also have these amazing gut bacteria that breaks down another kind of fibre called fermentable fibre, so that's found in foods like onions and garlic and leeks, and that can help maintain your blood glucose levels because they break them down very slowly. And during that process, short-chain fatty acids are produced, which among many other benefits help your brain recognise that it's full. Now we know that whole grains are important, but we have data from the Earth study, which is a really large ongoing study, and where they took a cohort of 273 women who had gone through a total of 438 IVF cycles. And they found that higher whole grain intakes 1 year before treatment is associated with increased endometrial thickness on the day of embryo transfer, a higher probability of implantation, so 70% versus 51% of women who had lower whole grain intakes, and a higher probability of a live birth, which led the authors to conclude that an increase of 1 serving a day of whole grains is associated with a 33% increased chance of implantation and a 27% chance of live birth. When we look at the effects of animal foods on fertility, though, it's a different subject. So animal protein, we have data from the Nurses' Health Study 2, which again is a really large ongoing study. It's been going on for decades. And they found that higher intakes of animal protein are associated with higher rates of ovulatory infertility. And surprisingly, chicken and turkey had more of an effect than red meat. However, a higher red meat intake is associated with a reduced chance of blastocyst development. So blastocysts are a ball of cells made by the egg on day 4 to 5 after fertilisation, and it's the first stages of embryo development. The study found that 1 extra daily portion of meat significantly increased the risk of OI, but replacing with plant protein significantly reduced the risk. Other components of animal foods that Rohini's just spoken about are ages, and these are formed in the body when sugars attach to proteins, and they're made internally, but also there are outside sources. And we have receptors for these throughout our bodies, including in the male and female reproductive tract. And if these agents attach to the receptors, they can cause damage to cells and DNA, which includes sperm and egg cells. In women, they can accumulate around the receptors in the ovaries and inside the uterus. So this can actually increase the risk of early ovarian aging and the inability of the embryo to implant because the uterus becomes so inflamed. So reducing dietary ages is a really important part of dietary recommendations. And one of the first things I always look at is really minimising or eliminating meat from the diet, especially dry cooked meat, because that really does increase the ages significantly. Dairy, the data is conflicting. So the Nurses' Health Study 2, there was no association found between total dairy intake and ovulatory infertility. Low fat was actually associated with a higher risk, and high fat with a lower risk, which goes against other studies showing that saturated fat has a negative effect on fertility. Another cohort from the Earth study, which looked at women going through fertility treatment, again, higher dairy protein intakes of just over or equal to 5% of energy was associated with lower antral follicle counts among women presenting for treatment. So if you have less antral follicles developing on the ovaries, overall your egg reserves will be lower. And what was interesting about that study is that when they replaced 2% of the dairy energy with plant protein, so that equated to about 7 grams of protein, which is about a serving of rice or a serving of chia seeds, the antral follicle counts actually increased by 5%. The study also found higher intakes of cream and yoghurt were associated with a higher risk of irregular periods. Again, further research is needed, but what we can say from the data is that dairy may have more of an effect on women going through fertility treatment, and the reasons may include the sometimes high saturated fat content, the small amounts of naturally occurring trans fats, the ages, and the animal protein itself. Now, fish is often associated with a healthy diet. For example, the Mediterranean diet is the most commonly studied plant-based diet because of beneficial nutrients including omega-3s. And studies have found associations with reduced rates of oocyte abnormalities, so that's the immature egg. Now, there are things to bear in mind. Is it the nutritional components of the fish and crustaceans rather than the fish and crustaceans itself, and where else can we get those nutrients from? Pregnant women are advised to not exceed 1 portion of oily fish a week because of the mercury content. And fish and crustaceans are vehicles for pollutants and pesticides, and unfortunately, with the ever-growing environmental crisis, this is likely to become worse. The effects on fertility and general health are unknown at the moment, but we do know that they contain microplastics as well, which may have a disruptive effect on hormones. And these microplastics also act as carriers for other chemicals. And they have been found in placentas, which show that we are ingesting and storing these microplastics, but we don't know the effects of that at the moment on fertility, and more research is needed. And I've just put a quite shocking stat there. So if you regularly consume shellfish, you may expose yourself to over 11,000 microplastic particles a year. And that's because shellfish filter seawater, so all of those microplastics are really concentrated in their digestive tracts. So that also includes things like whitebait that people will eat whole. Now, there are loads of key micronutrients for fertility, so I'm not going to go through them all because I don't have time. But if we look, for example, at choline, which is a micronutrient that quite a few women are concerned about. So deficiency is associated with reduced sperm motility, and it's important to support the growth and development of the placenta and the baby. And also it's really important to try and help prevent neural tube defects along with folic acid as well. And with choline, for example, if you have 100 grams of edamame beans, that will give you just over half of your daily needs of choline. And there are many other sources in a plant-based diet, so it's perfectly possible to achieve your needs with a food-first approach. So that leads us on to, can you have a healthy plant-based pregnancy? Well, the answer is yes, it's perfectly possible. It does take some planning, but that's the same for any dietary pattern. So looking at the composition of your plate, making sure you've got a good balance of macronutrients. So I always say aim for a quarter of the plate to be filled with protein source, quarter with carbohydrate source, and then fill the rest with fruit and veg, but do leave a good section for fats because they are so important. So looking at predominantly unsaturated fats, because not only do they help support a pregnancy, they also help you absorb fat-soluble vitamins, including vitamin A, which you have increased requirements during pregnancy, so that's really important. So other increased requirements are vitamin C, zinc, iodine, choline, iron and protein. And I've put a fact sheet here that you can download from Plant-Based Health Professionals, which is really, really comprehensive. a really useful fact sheet for anyone wanting to go through a plant-based pregnancy. What I would say with iron is that even if you increase your food sources, for example, tofu is an amazing source of iron, paired with vitamin C to aid absorption. A lot of women will need to go on iron supplements because the blood volume increases significantly during pregnancy. So always speak with your GP and make sure that they're monitoring that. Other important nutrients that don't increase during pregnancy but are really, really important are calcium. So that may protect against high blood pressure and preeclampsia. Calcium requirements increase significantly during lactation. So I would say always choose fortified milks and yogurts and go for calcium set tofu because that really does give you a really hefty dose of calcium. Also omega-3, which is really important. So it's recommended to have 450 to 500 milligrams of EPA and DHA a day, which equates to having a portion of oily fish and a portion of white fish a week for plant-based eaters. Folic acid is mandatory for the first trimester of pregnancy and also throughout the preconception period to prevent neural tube defects. And always look at food safety, so washing raw vegetables, avoiding raw sprouts. You can cook with them, but raw sprouts can contain harmful bacteria. And also unpasteurised foods, and most people equate dairy with unpasteurised, but also things like kimchi and sauerkraut are classed as unpasteurised foods as well. And avoiding caffeine and alcohol, even a small amount of caffeine is associated with an increased risk of miscarriage, and also you don't want to be drinking alcohol when you're pregnant. So supplementing correctly, folic acid, as I've said, mandatory, and also B12, iodine and vitamin D when you're on a plant-based diet. Vitamin D, most people will need to take it throughout the winter months, but there are groups that will need to take it all year round, so always check that with your GP as well. CoQ10 I don't routinely recommend, but there is evidence that it can help with women going through fertility treatment later in life, which unfortunately included myself, and also women going through IVF. And for men as well, there is some evidence it can help improve sperm quality, so I recommend, based on the data, there is no set guidelines, 100 to 200 milligrams a day is adequate. Some women prefer to take a pregnancy multivitamin. Of course, that's their own choice and is something I fully support if they would prefer to do that. So in summary, follow a predominantly exclusive plant-based diet, eat the rainbow, choose whole grains where possible, plan meals well during pregnancy, supplement correctly, look at other lifestyle adaptations as well, which are really, really important, and only seek nutrition advice from a specialist, registered dietitian or registered nutritionist, because unfortunately, as you probably all know, there is a lot of misinformation out there. So I'd just like to finish with showing you a copy of my book, which is available to buy downstairs, and also a fact sheet that I wrote along with the amazing Kate Dunbar for graphics, because I am completely useless on computers and wouldn't know where to start. So that, and they're my references. And as Rohini said, I'm happy for anyone to come and talk to me after this and answer any questions. Thank you.
Hello, everybody. It would be great if you could all stand up and stretch, because they say after 40 minutes you zone out, and that's 40 minutes of lectures done, so we could go for coffee now, or you could stay and listen to me. So, everybody enjoyed yesterday? It was a fantastic day, wasn't it? For those of you who were here, and I hope that you weren't disturbed by fire alarms throwing you out of bed, or staying up to watch Coco Gauff have a historic win. I hope all of you are really rested and waiting to listen to what I have to say. So, my name is Nitu Bajekal. Rohini is my older daughter. And I hope you come to the musculoskeletal health talk where my husband Rajiv will do a fantastic job, I hope, of chairing the session. So this brings us nicely on, because we were talking about conditions that occur in people who are assigned female at birth and who are women in the reproductive age with polycystic ovary syndrome and endometriosis and fertility issues. But many of those conditions actually linger on into menopause. And I myself became menopausal at the age of 38. Did I do anything? I don't know. So I myself became menopausal at the age of 38, a condition known as premature ovarian insufficiency. Although at that time, because of the toxic atmosphere that a lot of women used to work in 22, 23 years ago, I thought I was stressed, I was being a bit bullied, I was applying for consultant jobs. The last thing on my mind was, whether I was going through a much earlier menopause. There was no family history at that point that I was concerned about. And so I've gone on to write my second book, which will be out in February, called Finding Me in Menopause, because like a lot of my friends who said they weren't lost, I was, and a lot of my patients are. And so I wanted to bring together the holistic side, the lifestyle side, as well as the medical side, because it's not one or the other. My journey actually started in India. I did my medical schooling in the south of India, having grown up in Calcutta. For people who are familiar with India, that's West Bengal, and then traveled to Delhi. So I basically went all over India and then came to the UK. But although I trained to a very high level at all the top institutes, there was not a lot there was nothing about nutrition or lifestyle. There was something missing in my toolbox, which I would have also benefited when I became menopausal at the age of 38. And so that was lifestyle medicine, which I then finally went on to do a qualification as well. And I highly recommend people to do that. So what do you think this person is going through, this woman is going through? Perimenopause, okay? So, of course, again, these are diagnoses of exclusion, so you have to make sure you take a thorough history. But this is a 46-year-old woman who's noticed that her periods are coming more frequently instead of the usual 25 to 35-day cycle. They are coming every 23, 24 days. She's also noticing some skipping of cycles. She's also noticed some occasional hot flushes. And then just as she's going to go to the doctor and come and see somebody like myself or her GP, symptoms seem to improve and her periods have gone back to being normal again. And she thinks, this is all in my head, and she's not really wanting to have sex, and it's all a bit not here or there. And I know menopause is very topical, but there's not enough information as to what actually it involves. So while I'll be talking about the nutrition aspects, I do think I need to spend a bit of time explaining what the conditions are. So we are all born with about 1 to 2 million eggs at the time of birth, and you actually have more eggs when you're inside the uterus than when you're born. And then over the years, these eggs keep getting depleted. Every month you lose thousands of eggs. So whether you're on the pill or getting pregnant, you don't actually protect any eggs or save any eggs as such. And then by the time you come into perimenopause, the number of eggs deplete very dramatically. And so fertility, for example, starts declining steeply after the age of 37. And that's the single biggest predictor for if you want to have a baby. So for perimenopause, the average age all around the world is about 47 years, tends to be between 2 to 4 years of starting before you completely stop your period, which is menopause. So it's a retrospective. You can only look back and say, I was perimenopausal. And it can last 8 years, 10 years, and so you may not know, and you may actually be having those hot flushes, those panic attacks, and they may be actually the first signs of perimenopause. Your periods are getting a bit more crowded or spaced as early as in your late 30s, and that might be the first time you're thinking of actually trying to start a family and build a family. So it can be all quite complex. And this is the time when the ovaries start to fail. So those ovarian follicles that I talked about, all those eggs that you had been born with are now depleting quite rapidly, and so you start having hormonal fluctuations because the ovaries are one of the biggest places for your hormonal powerhouse, estrogen, testosterone, progesterone. And so that results in menstrual irregularities and then symptoms as a result of that. And of course, we don't talk enough about it, but actually bone loss and lipid changes and glucose control issues, they all start becoming a problem. And the Zoe Predict study with Sarah Berry in 2022 actually showed that those who are transitioning in menopause and in the postmenopause can have significant glucose issues, HbA1c issues, and they had women having about 1,000 women, and they had women having CGM monitors and things to try and work out, and they found that there are a lot of issues with glucose metabolism that hasn't been actually talked about before compared to women who are younger. And then, of course, coming from perimenopause. So perimenopause is the time leading up to your periods completely stopping. And to diagnose menopause is a retrospective diagnosis. That means you have to wait for a whole year when your periods stop to say that you're now postmenopausal. So no periods for 12 months with no other obvious cause. For example, you shouldn't have any thyroid issues or had a hysterectomy and things like that. So it's important to know that it's the final menstrual period. The average age all around the world is 51.4, but we do know, for example, women in India, the average, or South Asian women may actually stop their periods around the age of 47. And there are symptoms that are quite specific to early postmenopause and symptoms quite specific to after about 6 years when you have more of the cardiac issues and the bone health issues and the vaginal dryness and the painful sex, while the hot flushes tend to be in the earlier part. And this is when the number of eggs have dropped to a critical level. Some people say about 1,000, but the estrogen levels fall and your brain is telling the hormones to rise, the estrogen levels to rise. So you have FSH hormones, which is the follicle stimulating hormone from your brain, telling the ovaries, come on, buck up, produce more estrogen. So the FSH levels rise and the estrogen levels fall. And that is one of the main theories why hot flushes can occur. And there are several predictors that can shift menopause timings, this way or that way. Menopausal symptoms can be, there are about 34 symptoms described, and they can be short-term and long-term, like I said, but cardiovascular disease, bone loss, skin issues, they all can be issues. How do you diagnose? So please try and avoid going to clinics which will tell you to do hormone levels, because actually it's a clinical diagnosis. After the age of 45, you don't need blood tests to tell you that you're menopausal unless you have a Mirena coil and you don't have periods and there's confusion. So that a specialist will help you decide. But if you're under the age of 40, you do need specific tests. And if you're under the age of 40, you need to be referred to a specialist who actually understands POI. Okay? So when you come to managing menopause, estrogen is the most effective form of treatment. And so hormone replacement therapy can be life-saving for a lot of people. But a lot of women don't want to take it, and a lot of women can't take it. And we have about 3 decades from menopause, around the age of 50, and the average life expectancy is about 83 years, even 88 years in Hong Kong and things. So you have all those years, and most women will not be taking HRT all that time. So you do need to encourage yourself and your patients to follow lifestyle. It's never too early and never too late. And strength training is one of the big important things that you need to focus on for your patients, as well as stress management, but also encouraging them to bring in more whole plant foods. Not necessarily that we have all the evidence for a completely plant-based diet, but we know if we are going to be looking at climate change and all the other aspects, then it makes sense to eat a plant-exclusive or a significantly plant-predominant diet. And so you really want to focus on all these foods, including herbs and spices, and especially beans, lentils, peas, and soya, because they have got plant estrogens, and I'll be talking a little bit more about that in some detail. You want to avoid the foods on the right-hand side, and you want to minimize salt, oil, and sugar. I'm not a fan of a low-fat plant-based diet. You want to bring in the nuts and seeds and the avocados, and if you want to avoid oils, that's fine, but some amount of extra virgin olive oil, if you don't want to shed weight, then that's fine. But generally speaking, you want to focus on the whole food sources more than the liquid sources. And so we focus on the most common symptom of hot flushes. Only 2 or 3 out of 10 women will actually seek help. But we know that the number of women that suffer with hot flushes in the Western world or in the global North compared to the global South is actually much higher. And that may be because they don't report it, but also it might be that they are having more plant-based diets and are not really having this low-fiber, high-saturated fat diets that we tend to have typically in the standard American or standard Western diet. We also know that smoking, saturated fats, and we've talked a lot about advanced glycation end products. All these can worsen hot flushes significantly. And body weight, so losing weight, there was a study with 10,000 women losing about 5% of their body weight, improved their hot flushes. So I have lots of references. Please don't need to take any notes. All this and much more is on my website. You can see nitubajekal.com. You can actually go on there and download all those free fact sheets that are there, and much more detail in the book that I've written and the book that's going to come through. What we found was there was a survey of vegans, and vegan women were found to actually have fewer hot flushes, while another study showed that the more vegetables and fruits you included in your diet, the lower was the risk of having night sweats and hot flushes and vasomotor symptoms. Most of the studies seem to focus on the acute symptoms rather than the longer-term symptoms of osteoporosis and heart disease and things. But more women die of heart disease than men. And we know that from this study that those who were having solid fats and snacks and mayonnaise and sweets and desserts actually suffered more. And also, a lot of them would have had more inflammatory body status and higher body weights in this situation as well. A little bit about soya. So, soya is something that causes a lot of confusion even in the plant-based community. Okay, so the first thing I'm going to tell you a little bit about the study on menopausal symptoms, and then I'm going to go in a little bit more detail about soy. But soy intake has been shown to reduce hot flushes in Southeast Asians. But there was actually a very neat randomized control trial run by Dr. Neil Barnard, which showed that they looked at 84 women, divided them into two groups, and basically found that when they fed them a low-fat, plant-based diet, along with half a cup of mature soybeans every single day, the incidence of hot flushes reduced, severe hot flushes reduced by 84%. Now that is fantastic news, okay? And that was only a short 12-week study, but if you actually include that same amount of soy in your diet on a daily basis, bringing in the same amount of isoflavones, without focusing too much on the low-fat stuff, there's no reason why many of you cannot benefit this, whether you need HRT or not, okay? I'm not here to knock HRT. And there have been lots of other studies showing supplements can also help, isoflavone supplements, but they're not of good quality, not high strength, and I generally tend to suggest a food-first approach like Rohini does. So what is soy? Soy is basically a plant estrogen, a phytoestrogen. It has got lots of other things. It's got protein and fiber and minerals and vitamins, but it also is very rich in plant estrogens or phytoestrogens. But the good thing about soya is that it works only on the beta receptor, unlike the mammalian estrogen, which works on the alpha and the beta receptor. So what happens is it can promote the growth of tissue in certain organs, and it can actually halt it in certain organs. So that is why it has got this sort of Jack and the Beanstalk magic bean effect, where it works on bones to prevent osteoporosis and reduce the risk of osteoporosis and reduce the risk of breast cancer, but also at the same time promote good health by reducing hot flushes. And there are plant estrogens are not only in soya. There are several types of phytoestrogens, so isoflavones, lignans, and coumestans. But if you can't take soya because you're allergic in the tiny group, then you should focus more on the lignan group. But it is really important to make sure that you're not truly allergic or allergic to all the influencers who are telling you that they should not be having soya. So it is safe, it's good for you, and it's not just for hot flushes, it's not just for you, it's good for your children, it's good for the men in your life because it's cardioprotective, helps with weight loss, slimmer waist, lipid profile improvement, skin aging, better vaginal lubrication, and also reduction in a whole host of cancers. Womb cancer, ovarian cancer, liver cancer, breast cancer, prostate cancer, even those with breast cancer who were estrogen positive and on tamoxifen had a lower chance of dying when they ate soy regularly. How much should you eat? I recommend anywhere between 2 to 4 portions of soy every single day, and that would give you all those 55 milligrams of isoflavones that you need, and that would be a cup of soy milk, a handful of tofu, maybe a cup of soy yogurt, some tempeh, some edamame beans that you can eat instead of popcorn, so things like that. Thyroid medication is not a contraindication. Just space it out, your medication, thyroxine, because they compete for the same receptor. And make sure that your patient is actually up to date with their iodine intake. Salt is not iodized in this country, and we don't want to be eating a lot of salt anyway. So you want to take about 140 micrograms of iodine every single day and not overdo it with seaweed and things as well. So you can manage hot flushes with or without HRT, using some lifestyle changes, simple things that you suggest to your patients, but also trying to bring in the stress management, the hypnosis if they want to do, the meditation, the acupuncture. Those can help certain individuals, and a whole food plant-based diet with an extra focus on beans and legumes and lentils and plant estrogens. And we know that those who actually eat more of a plant-based diet, they synthesize the soy products much better because they're known as equal producers. They actually digest it better. So I'm going to finish off with a little summary so that we have lots of time for questions. So perimenopause tends to occur anywhere between 2 to 8 to 10 years before your final menstrual period. Menopause is a retrospective diagnosis. It takes 12 months before you can say, I've had no periods for 12 months. Now I know I'm menopausal, and you're going to remain in that menopausal stage, or your patient's going to remain in that menopausal stage until they die. A lot of people say, oh, I've finished with menopause. No, you've never finished with menopause. Sadly, because initially you may have those hot flushes and night sweats and mood swings and panic attacks and reduced sex drive. It comes back, and then later on you have a dry vagina. So when you think that you're over all the things, and you start having cardiac issues and bone issues and lipid issues. So it's really important. With polycystic ovary syndrome, menopause is delayed by 2 years, but you can actually have some other worse metabolic symptoms later on compared to those people who don't have PCOS. Similarly with endometriosis, just because you've stopped your periods, endometriosis doesn't go away. You may still be left with scarring and adhesions, and you still may need surgery. There are 34 symptoms. The most common age is around 51 to become menopausal, but the range is between 45 and 55. South Asians tend to be earlier. Hot flushes are the most common symptom, but you must remember you can have all symptoms from tinnitus to jaw pain to burning mouth to formication, all kinds of symptoms. Local vaginal estrogen is safe and effective and can be used until you're 110. And HRT is also safe and effective for the vast majority of people, and you should not deny your patients on the basis of studies that are outdated and haven't been interpreted properly. You must recommend your patients avoid bioidentical hormones because they're not standardized. Because a lot of women go to these clinics thinking that they're natural. Also stay away from most herbal supplements, because if they were good enough, they would have gone through a randomized trial like red clover and would have come onto the Western medical system. So it is very important that natural does not equal safe. And a standard American diet makes symptoms worse. You can make a huge difference with your symptoms going with a plant-based diet, especially a whole food plant-based diet, and a low fiber, high saturated fat, high AGE, advanced glycation end product, barbecued foods, fried foods, animal foods will worsen your symptoms. A dinner like mushrooms with brown rice will actually lower your symptoms. Having lots of soya in your diet, between 2 to 4 portions, it reduces hot flushes, has other non-hormonal benefits, and is safe if you have cancer. And that's my website, and I'm on, I don't know what I'm on. I'm on Instagram, and I'm on TikTok, and all those wonderful sites, especially the BMS, the British Menopause Society, is a fantastic site, and Eve Appeal and Daisy Network for those who have earlier menopause, POI as it's known. Thank you.
Thank you, everyone. You can have a quick stretch. Just stand up and quickly stretch. We're going to have a break anyway in just about 20 minutes. But we've got a lot of questions because you are all a curious bunch. So let's get cracking. So the first question is for Lisa. There's been a big emphasis on female fertility and diet. What about the male diet?
Yes, oh, is that working? Can you hear me okay? Okay. I'm a huge advocate for including... I don't know. Oh, I feel like I'm going to eat it.
I think you're going to put your chair right
Is that better? Okay. Yeah, I'm a huge advocate for including men in the conversation, which is why I've included male infertility in my book as well. So I talk about that at length. There is loads that can be done to improve sperm quality by looking at lifestyle changes and incorporating more plant foods into the diet as well.
Definitely, and you address this in your book as well, there's a whole chapter about it and kind of talking about that and the specific nutrients like zinc, selenium.
Yeah, zinc is hugely important. Zinc, men lose zinc in every ejaculate, so their requirements are a lot higher than women. So I always advise men to include an extra portion of seeds every day, which will really boost their zinc intake.
I also think that you need to educate men that infertility or fertility issues can affect 2/3 of the men as well. So 1/3 is a male issue, and then another third is both male and female factors. And people often think it's always the female. So I just think as health practitioners, you must make that very clear that it's not just a one-person thing. You need, like Lisa said, bring them both into the conversation.
This question's for you. So why do you need to take a multivitamin with the combined oral contraceptive pill, and why is inositol important? So answer the first one first.
So the first one is the combined pill has got huge numbers of benefits, but there have been a couple of small studies to show that there may be some disturbance of the gut microbiome. So if you are somebody who's on long-term pill, because you can take the pill from the time you start your period until the time you're menopausal safely for women who have no contraindications. So you can have a break once a year, once in 3 months, whenever you want. But these couple of studies have suggested that you would be better off having some micronutrient deficiencies with the pill. So to try and prevent that, I would always recommend a multivitamin, multimineral supplement if you're going to be on the combined pill, which has got a lot of benefits, especially for PCOS and endometriosis and fertility, effective contraception.
Could you also mention cancer concerns that people have around the pill quickly?
Yeah. So the pill, if you take the pill for at least 5 years in your lifetime, you halve your risk. Okay, listen to this. You halve your risk of getting ovarian cancer and womb cancer and bowel cancer. So the longer you take it, the lower are those risks. Okay? And when you stop it, so say you stopped it after at 26 or 30, that risk reduction remains until the rest of your life. That is very important to remember. There's a slight increased risk of cancer, and those are 2 cancers. One is breast cancer. If you take it for more than 12 years, there's a very tiny risk, but that's 1% increased risk compared to 8% with increased body weight, 8% with drinking alcohol. So you should not deny your patients of taking the pill. And as soon as you stop it, that risk goes away. The second cancer risk is cervical cancer, and we're not entirely sure why that is. So slight increased risk in cervical cancer if you're taking the pill. We don't know whether it's sexual behavior. We don't know. We don't have enough studies. But as soon as you stop, the cervical cancer risk goes away. Inositol is mostly found in whole grains and whole plant foods, but there is a good reason it's safe, it's effective for giving it to women before, alongside the whole food plant-based diet lifestyle and other things, before they do other stuff. Myo-inositol can help to actually sensitize insulin and bring in, improve ovulation in those, especially with polycystic ovary syndrome. But we'll go into details about, because these are all huge topics. People specialize just in these individual topics, trying to squeeze it in 20 minutes.
Someone's asked about any foods being high in beta-glucans apart from oats. So beta-glucans are a type of soluble fiber, and they've had a lot of interest recently because of their potential role in benefiting people with metabolic conditions, metabolic syndrome, obesity. And they are found in a variety of foods. And actually, the food that contains the highest amount of beta-glucans as soluble fiber is barley. But you can also find it in things like nutritional yeast, obviously a vegan favorite. You can add that into lots of dishes. And nutritional yeast by weight is 50% protein. So it does contribute a small amount, and you keep adding it in. And mushrooms are a fantastic source. Mushrooms do benefit immune function as well, and they're rich in things like selenium. So shiitake, maitake mushrooms are very rich in beta-glucans as well, and some seaweeds, things like rye. So yeah, getting that diversity of plants in is key. You don't need to fixate on one food or one supplement. It's getting that variety in. This question's for Lisa. This is going to be a quick fire because there's so many. Lisa, how does high-fat dairy help with fertility? And I know a lot of fertility clinics do tell their patients to consume a litre of milk every day. What are your thoughts on this?
Yeah, it's probably from the Nurses' Health Study too, which showed an association with high-fat dairy and lower rates of ovulatory infertility. But the data is so conflicting, and you'll find many other studies that show that dairy has negative effects as well. So I think these fertility clinics, well, a lot of patients come to see me who've been told to increase their meat intake as well because they can't get pregnant without having high meat intake. So I think they need to get up to speed with the latest evidence and stop causing harm, because when patients are told by a consultant that they need to drink lots of milk and eat lots of meat, then it's quite hard to then, talk them around. So I feel very strongly about that.
Brilliant. Would the same dietary guidelines and lifestyle modifications apply to people living with fibroids, which is, again, a very common condition? And there's a great fact sheet on the website.
So again, 1 in 2 women will be born with fibroids, more in certain races, but we do know that increased body weight, alcohol, especially beer, not exercising, red meat, all these will increase the incidence of fibroids, but also symptomatic fibroids. In fact, there was a study where it was shown that women who ate fish actually had a higher, this was an ultrasound study, and they found that they had more symptomatic fibroids than those who didn't eat high levels of fish. So diet can make a difference, but as usual, as I always say, there's a whole specialty called obs and gynae, but the research is woefully lacking. There was a study to show whether women with endometriosis had bigger breasts, and I was thinking, how do people find money to fund things like that when there's more important questions to be answered about endometriosis? So it's just fascinating. So yes, fibroids, there is no separate diet to look younger, to prevent cognition decline, to prevent cancer, to reduce menopausal symptoms, to improve PCOS symptoms, to improve fertility, to improve strength. It's the same diet. You just have to make little tweaks sometimes, but the diversity of plants that you want to eat, whether you eat a bit of meat or fish or dairy or whatever. And I think one of the reasons why they did talk about dairy, Lisa, I think is, first of all, doctors get their nutrition advice from the Daily Fail, so they basically do not have enough information. But also, I think people's diets are so poor that bringing in dairy in those days in the Nurses' Health Study and things were actually a better health benefit than the other rubbish that they were eating.
Totally. So is it easy to get your GP to look into whether you have PCOS, and what sorts of tests should you ask for? And I should also definitely say the first port of call should be your GP, not your friend or relative who might know about PCOS. Go and see a doctor if you think that you meet that criteria, or even if you have any suspicions with the symptoms or anything like that, because and try and empower yourself with that knowledge so you go in informed.
I would say the first port of call should be reading our book. Not because I have no interest in the sales of the cost, because it does nothing for my bank balance. But what I want you all to understand is you need to know the questions to ask. And we have questions even in my next book, because you need to empower yourself. Because doctors are busy people. They may not know necessarily enough about the condition. And so you do have to empower yourself. You do have to think, what are the questions I want answered, and what are the tests I want, rather than going and doing this, that. Because, you have so many different. You may go to see a beautician for your hair removal. You might go to see a dietitian for your weight loss. You might go to see your GP because you're not being heard. You're going to see a gynecologist like me because you're missing your periods, fertility specialist, an endocrinologist. Nobody's joining those dots. And who's going to join those dots? You. So you need to empower yourself. So if you can't afford the book, go on my website. It's all free. I want you all to read. I want you to empower yourself and empower your patients.
And we've both spoken on lots of podcasts that are obviously free as well. One of the questions that was great was about, someone who has a friend who's a lean athlete and they have hypothalamic amenorrhea. And and they're anxious about training less and eating more, and it can be a source of real concern for people when they're dealing with this. So hypothalamic amenorrhea affects significantly less women than PCOS. It's about 3 to 5%. Usually women under 30, but it can happen at older ages in the reproductive cycle as well. And again, it's that kind of dysfunction in the HPO axis. And basically what happens is when our body fat gets too low usually, and when we're under fueling, our body's trying to preserve energy for the most critical functions. So it's trying to shunt that energy to the organs for survival and health. And this can happen in people at different body weights. So you don't necessarily have to have an underweight BMI to have hypothalamic amenorrhea. Women can have it at higher. You could have a BMI of something like 23, and actually because of your body composition, you're very muscular and have very low body fat, you can see that. But a lot of the time you'll see that lower BMI side of things. And I have seen this with people who sometimes have gone newly whole food plant-based. They've gone very restrictive. They've cut out all oil, all fats pretty much, no soy. They're eating a very raw food diet and they think it's very healthy, and then they lose their period. They notice skin and hair changes, and sometimes they can be the walking well, so they don't notice any of those symptoms of estrogen deficiency that you get more in the menopause. But it's really, really important to fuel your body correctly. Doesn't matter what your body size is, you do need to be eating adequately and fueling yourself. Having very low calorie diets of like 800 calories a day is unsustainable. But there are little things that people can do to ease their concerns. So firstly, working with a registered dietitian, ideally specializing in this area of, it's called REDS, Relative Energy Deficiency Syndrome in sports. And there are lots of dietitians out there who specialize that, and someone who's going to guide you, because everyone is very individual, and some people might need to stop training for a while, other people can still train but make other tweaks. But usually one of the top few things I'd recommend is stopping fasted training, and I actually don't recommend that for women in the reproductive age group anyway. It can be really quite hard on your body. You've got the highest levels of cortisol in the morning, so even if you get something small in before your run, like a banana with peanut butter, it can go a long way. And fueling regularly, sometimes people go for long periods without, intermittent fasting, 16 hours a day eating nothing. That can lead to an increased risk of this. And increasing carbohydrate content. The number of women I see where they think they're eating a healthy diet, it's Greek yogurt for breakfast, salmon salad for lunch, and that sort of style of eating, and just including more grains and more starchy vegetables in can help restore their cycle. And I've seen so many women who've got their cycle back that I've worked with. So I've got a great fact sheet on gaining weight healthfully on a plant-based diet on the Plant-Based Health Professionals website, but that's really covers it. So in a way of doing it that's actually nourishing your body, you're not just being forced to pour double cream on everything, which isn't something that probably most people who are athletes or have this condition would want to do. One of the great questions that came up was about when do we need to make lifestyle changes in the preconception period to kind of influence epigenetics and fertility? When do you suggest that people who are trying to get pregnant make changes?
So if there are no underlying issues, I always say 3 months or more, because it takes around 3 months for the egg and sperm to develop. So you want to be making changes just before that time. Really, the longer the better, depending on your baseline. So if you've got a lot of changes to make, or if you're significantly underweight, because there's a lot of focus on women who may be carrying excess weight, but there's not so much on women who are significantly under, and that can really, really impact your chances of conceiving, but also the health of the baby as well. So 3 months, but if there's any risk factors, then 6 months or more.
Super. There was a question about plant foods. Are there any plant foods like cacao that can increase the risk of miscarriage? And perhaps we could address that.
So we're looking at caffeine content. So it's important to know that it's not just tea and coffee that contain caffeine. So dark chocolate contains a lot of caffeine as well. And there are also some herbal teas that contain a lot of caffeine, for example, green tea. So always double check with herbal teas, that's really important, and just minimising dark chocolate intake in any form, and foods that it might be contained in, as well as looking at your tea and coffee. And just bearing in mind with coffee as well that it's quite shocking, because if you order a large coffee in Costa or Starbucks, you're looking at 5 to 6 shots of caffeine in a large coffee. In a small coffee, there's 2 shots. And it just gradually gets worse as you go up. So just be aware of that even a small coffee in a takeaway shop contains an awful lot of caffeine.
And small amounts of caffeine can increase the risk of kind of preterm birth and smaller size birth and things like that. But I will just also say that miscarriage and baby loss is not someone's fault, and 1 in 4 pregnancies do end in a miscarriage. So don't blame yourself for having a bit of dark chocolate or a coffee or something like that. But yeah, it's good to be aware of the research, and Lisa's book spells that out, but I just want to say that. I also want to just quickly ask one more question about race and PCOS. Someone's asked about the impact, what role does race play in PCOS, and is it higher in certain
Race
ethnic
plays
groups?
a role in almost every chronic disease. And in PCOS, we've seen that studies all over, especially in the UK South Asians and in Indian South Asians, Hispanics, Indigenous Australians, all of them tend to have a much higher incidence. Whether they have excess body weight, none of that, all being controlled, they still have an incidence of 1 in 4. So that's much higher than the 1 in 10. Same thing with fibroids. We also know that that affects more of people from African American women tend to have higher incidence of fibroids, and so often they'll get dismissed because they are not recognized the pain that they have to go through, or fertility issues, because we are not used to, especially in the UK, generally Caucasian women have a much lower incidence of fibroids, and so fibroids, polycystic ovary syndrome, endometriosis, I don't think there is that much of a ratio, but generally speaking, because there's a lot of historic inequalities as well. So we know big studies have been done where women have been left out of studies just because of their race. So we don't have enough research on it. But generally speaking, I would say that if you are somebody from a minority community, you may well be exposed, not just from your race, but also from the inequalities in society that may have been faced when you come up in the countries that you live in. But I have a whole chapter in the book that deals with, I don't know what it's called, it's unfair, or it's not fair.
It's about
and
different groups.
About medical racism, because we know that medical racism is rampant. People who live in larger bodies have even more mistreatment than those who are people of color or people with disabilities. And again, these things have to be addressed, because it's not only about, that's why when I use the word woman, I always say I want to include women who are assigned female at birth, because people who are on the fringe don't often get a say, whether it's menopause or perimenopause or PCOS. Everybody needs to have a voice.
Just to say quickly, someone asked about tempeh and kimchi and things like that in pregnancy. Unpasteurized food is probably better avoided in pregnancy, but you can get pasteurized kimchi and things like that. It really, it's an individual choice. Tempeh is actually safe because you tend to cook tempeh. I wouldn't really suggest eating tempeh raw out the packet. Tofu is already cooked and things, so it's safe. But yeah, maybe things like raw sprouts, just be a bit aware of bacterial contamination. And I will just ask one last question, because it was so upvoted, and this is to you. It's about, what's your advice for women going through menopausal symptoms like severe hot flashes who've had breast cancer in the past and are now in remission?
So you do need to take the advice of your specialist, your oncology team, but I would strongly suggest 2 things. One, reading a book called Breasts by Dr. Christy Funk, who is, what's her name, Angelina Jolie's breast surgeon, and focusing on certain foods. So trying to eat a exclusive whole food plant-based diet, exclusively teetotal. I know it's hard, but those are things that because I see a lot of patients who have had breast cancer, who have breast cancer, and this is not a place where I personally would say a little bit of this is okay or a little bit of that is okay. And I would be recommending a exclusive whole food plant-based diet with focusing on things like even a single button mushroom can help reduce risk of recurrence and risk of breast cancer. Green tea, if you like green tea, and remembering that it's got caffeine, so you drink it early in the day. Flaxseed, so you want to have ground or milled flaxseed, a couple of tablespoons of flaxseed every single day, and 2 to 4 portions of soya in your diet, ideally minimally processed soya. So tofu, tempeh, edamame beans, soy milk. And we know there are huge studies in China which have shown that the outcomes are so much better when people have a history of breast cancer and they include soya in their diet. But if you're confused, the sad thing is you will go to your oncology team, they'll either not know or they will tell you, stay away from it. Yes, stay away from the isoflavone supplements. Do not take supplements. Instead, take the whole food. Nature is smart.
Thank you, everyone. Thank you so much. Please.